everyone. Thank you so much for letting me participate in your workshop, and I'm going to present about neonatal seizures and meningitis today. And my name's Jill. I'm a nurse here at the network. I work in the neuroscience ICU. I've been there for 10 years. Prior to that, I worked in med-surg for about 4 years. So I don't have experience in the neonatal population. I have a little bit of experience with pediatric neuroscience, neurocritical care patients. So I talked to Kathleen a lot, and I did a lot of reading, and I put these presentations together. If there's anything that doesn't align with what you see or what you've learned, please feel free to point that out. And if you have any questions, don't hesitate to ask. I'll be here all day. You can email me. And if you have a question today that I don't know the answer to, I can certainly find out for you. So we're going to start with seizures, and we have some objectives. We're going to identify the potential causes of seizures in neonates, differentiate between the most common types of neonatal seizures. We're going to discuss the care and treatment of neonatal seizures. So what is a seizure? It's an abnormal electrical discharge from brain cells, cerebral neurons, that cause clinically detectable events. So they might be behavioral, they could involve rhythmic movements, you might see eye deviation or eye fluttering, and there might be vital sign or autonomic changes, specifically apnea and tachycardia in the neonates. So neonatal seizures, they can be difficult to recognize because the signs are often subtle. And one of the reasons for this is the immature central nervous system in the neonate. It's not developed enough to sustain a generalized seizure. So the generalized, tonic-clonic, prolonged type movements that you might associate with a seizure in an adult, the infant CNS, it's not developed enough to do that. So you're going to see shorter spurts of abnormal activity. The incidence is highest in the neonatal period than any other age group in the lifespan. So seizures do occur. For infants weighing less than 1,500 grams, it's about 5%, give or take, and then 2,500 to 4,000 grams, much less occurrence, but they still do occur. Who is at risk? Definitely any type of metabolic and electrolyte disturbances. So we're going to be looking at the glucose levels, the sodium and calcium levels, looking at the metabolic, the acidotic. Any type of ischemic or hypoxic events can contribute to seizure development, infection, toxicity, any intrapartum trauma, or maternal drug withdrawal can be a factor, also genetic predispositions. And from the literature that I reviewed for this, those are more rare. Typically it's going to be something like ischemia or an infection or a metabolic type scenario. So we talked about HIE on Wednesday, hypoxic ischemic encephalopathy, HIE. That's the most common cause. That's going to account for up to 80% of seizures in the first 2 days of life. Other causes, brain damage from prenatal distress, developmental malformations in the brain, stroke, intracranial hemorrhage, subarachnoid hemorrhage, infection, so meningitis, which we're going to look at more closely, and other infections such as torch. So the most frequent types of seizures are subtle seizures in the neonate. These often go unrecognized, and their presentation varies quite a bit. It could be eye deviations, maybe a deviation to the left side, could be eye twitching or fluttering, rapid blinking. You might see pedaling, rowing, or stepping type movements, sucking, lip smacking, drooling, or there might be episodes of apnea. Kathleen was helping me prep for this procedure, and she shared an incident when she was taking care of a baby one night in the NICU, and he kept having periods of apnea over and over, and there were no other signs of seizure, but it was just consistent periods of apnea all night long, and then it turned out that he had been having seizures. So here's the video, I hope it works. So this is gonna show the subtle seizure. This is actually a pretty good video. I have a link at the end if you're interested. If you're a visual learner and you kind of want to see the different types of seizures, this is a pretty good one. The woman does have an accent, but she's easy to understand. Let's see. Kathleen, you need to help me run this. Oh, it might work here, sorry.
Seizures.
You can make it big
So
too,
oral
more.
USG.
It's loud, how do I turn the volume down? Cool, thanks.
The manifestations are mild and frequently missed. So in this video you can see the newborn is having a subtle seizure, having frequent eye movements. So in eyes, tonic horizontal deviation of the eyes or sustained eye opening with the ocular jerk fixation or cycled fluttering or jerking movement of the eyes can be there. In this video you can see the newborn is having the sucking and praying movements. These are also the subtle seizures. So oral, facial, lingual movements in the form of chewing, sucking, lip smacking are the form of subtle seizures. Subtle seizure can be present as a limb movements in the form of cycling, paddling and boxing as is present in this newborn also. Autonomic phenomena, tachycardia, bradycardia can be there. And in term babies, it can be manifest with the apneic attack also. So
I thought that was a good video because it shows the two different types of subtle seizures that you might see.
Did you click on this one? Now she's done.
So the next type of seizure is more common in neonates are focal clonic seizures. This is localized clonic jerking. They're slow, repetitive, rhythmic type movements. They're uncommon. They might occur with structural lesions, infection, or in a cranial hemorrhage. I actually found a good video of this type of seizure as well. This one's really short. There's just a disclaimer. I thought it was interesting that these are rare, but there was actually a good video online of this one. This is a 2-day-old. And you see the rhythmic, slow movements. So another type of seizure you might see is a multifocal seizure. These are seen usually in term infants with HIE. Clonic movements migrating from one limb to another, and you'll see random movements and usually no specific pattern. Then tonic seizures, these occur in premature infants, super lightweight premature infants. They can be associated with a severe interventricular intracranial hemorrhage. They're sometimes associated with poor prognosis. So you might see eye deviations or apnea, and sometimes you'll see posturing, so the decorticate type posturing. A myoclonic seizure is synchronous jerking of extremities. It could occur in the upper or lower limbs. You might have single or multiple jerks, and these are rare in the neonatal population. So possible causes of seizures in the first 24 hours, this is kind of a recap: HIE, meningitis, IVH, intracranial or intraventricular hemorrhage, infection, or drug withdrawal possibly. It's kind of, I talked about the different types of seizures. What's most important is to be able to recognize the abnormalities. If the infant's having abnormal eye movements or twitching, you don't necessarily need to be able to say, I think my baby's having a myoclonic seizure, but you need to be able to recognize the signs of seizure activity. It's something abnormal, it needs to be addressed and worked up. So it's also important to differentiate jitteriness versus a seizure. You might see trembling or tremors in the neonatal population. So you see trembling of the hands or the feet. One way to discern if it's jitteriness versus seizures is you're not going to see eye deviation or eye movements with jitteriness. Also, if you gently flex the affected extremity, the jittery, trembling movements should stop. And with a seizure, that won't happen, the movements will continue. And you're not typically going to see autonomic changes with jitteriness. So the assessment and plan, if you're taking care of a baby that's having seizure activity, what are we gonna do from a nursing perspective? We're gonna make sure we have vital signs. We're gonna do a physical exam, including a neuro exam, you know, as much as you can. The neuro exam is very difficult in the neonatal population. Going to review the infant's history, the maternal history, the history of the birth. Did anything abnormal occur? Were there events that could have contributed to hypoxia or ischemia? And we're going to anticipate a workup. So we're probably going to get some new orders. What does anyone know, like what type of labs you would probably see ordered for somebody developing seizures?
Electrolytes?
Good, yeah, electrolytes definitely. They might probably, very likely do a septic workup, so that's gonna involve blood cultures, urine cultures, and likely a lumbar puncture. And then they're gonna probably have some diagnostic tests as well. So the diagnostic tests would do an EEG, an MRI, cranial ultrasound. If there's any possibility of trauma or history of trauma, they'll do skull films. And as I said, they might do a lumbar puncture. The EEG can be tough. The EEG is the way to diagnose seizures. They'll be able to correlate the abnormal seizure activity with the abnormal brainwave pattern on the EEG. But there's a lot of barriers to doing a good EEG in any population, particularly with the neonate. If there's movement, there might be a lot of artifact. Seizures aren't always captured on EEG, but it's ideal if we can to guide the treatment plan. So the goals of treatment are to determine the underlying cause, keep the baby safe, nothing in the mouth. You don't want to restrain the baby in any way, but keep them safe. You want to stop the seizures and prevent long-term brain damage and provide education and support to the family. So medications, phenobarbital is the first line medicine for neonatal seizures. It's, you have to definitely monitor respiratory status. You'll typically give a loading dose. And then if the baby continues to have seizures, refractory doses can be given. Phenobarb is excreted by the liver, so we have to monitor the drug levels and also check, you know, for jaundice, hepatomegaly, stuff that would be affected with the liver involvement. Some infants require more than one medication to control seizures, or if phenobarbital doesn't work, there's other medicines. fosphenytoin, which is also known as Cerebex, and Dilantin. One of the advantages of Cerebex is it can be given IM if you don't have IV access. Dilantin needs to be given IV. It's extremely harsh on the veins, so you have to really keep an eye on that line. Make sure the IV hasn't infiltrated because it can cause tissue necrosis. It's also important to have therapeutic levels of Dilantin, so you're going to be watching for toxicity. Other medicines, benzodiazepines, lorazepam, Versed, sometimes Valium diazepam is used as well. And when we're treating seizures, we need to be super aware of what the medicine can potentially do to the infant. So you want to make sure that they're adequately ventilated, that they're perfusing. Because some of these seizure medicines can cause decreased respiratory drive, they can make the infant more sleepy, they can have different effects on the vital signs. So you want to be prepared. If you're giving the first dose of phenobar, you want to make sure you have a plan, maybe let respiratory know. Just be prepared for them to have changes in their presentation and be ready to treat that. So outcomes depend on the underlying cause. Mild HIE and subarachnoid hemorrhage, they're usually associated with good outcomes. Complications, they might develop epilepsy later in life. If you have seizures in infancy, that can lower your seizure threshold as you grow up. So you're more at risk for developing epilepsy or having seizure activity later in life. There can be learning and motor problems. It's really important to educate families that these patients need close follow-up with their pediatrician, possibly a pediatric neurologist. They should be educated on the signs of the seizures, the plan for medication. The medication plan, again, really depends on how the baby responds to treatment. If we can get the seizures under control and they stop seizing, they might not need to go home on anti-epileptic meds. But if it's been a harder thing to control, they might need the anti-epileptic meds after they leave the hospital. So there needs to be a lot of instruction and education with the family to make sure that they're comfortable and they know what to do, what signs to look for, what to report, and just can't stress enough the importance of just close follow-up once they leave the hospital. So these are the references. I know Kathleen mentioned on Wednesday this book. It's the third book, The Core Curriculum for Neonatal Intensive Care Nursing. That's a great book. It's presented in outline form, so you don't have to read paragraphs. Just go through the index, find what you want to learn about, and it's all like outlined for you right there. It's really good. It gives references, the latest evidence. So I really recommend that book as a resource.
I do have it in my office if anybody wants to borrow it.
And then I always look through the nursing literature, and the only article I could find on neonatal seizures in the nursing journals was from 1994. And it's a good article, it still holds up, so I did include it. But that's definitely, if you're interested in seizures or if you see a lot of seizures, it's definitely something you could probably do a poster presentation on, because there seems to be a dearth in the nursing literature about seizure management in neonates. And these are the video links. This, I did find a video of a focal tonic seizure, but it won't link. I think there's like a privacy protected thing on the video, which makes sense. But there's definitely videos there on YouTube if you know, to help connect the dots. So that's it for seizures. Any questions? Yeah, hi.
So I just have a question about like the meds. So say like your baby is having seizures and they do a BMP and they find like, oh, they know it's an electrolyte imbalance. Will they go right to giving the meds, or will they try fixing the electrolyte imbalance first, since like these meds have negative side effects?
That's a great question. I would say they would definitely fix the electrolytes.
So it's not
first.
like immediate that you need to like start like giving them the anti-epileptic meds. Like
Yes.
you can like try and fix the cause first.
Great question, absolutely. address the underlying
Yeah.
cause. That's
I was just wondering,
great
like,
point,
how
no.
quick, yeah, how quick
No.
they are to like give these meds to neonates.
Yeah, definitely, there's always a discussion, a pro and con, you know, of course. And yeah, that's really important, address the underlying cause, because yeah, sometimes they can be corrected and they don't need the medicines, and the medicines have side effects, and it's also unpredictable side effects, so yeah, that's a great question. Yeah. And that's why it's important to know the history, you know, or to have a, you know, after you get a report, when you're getting ready to start care, you know, glance at the labs, like have an idea, even if something is like on the low side of normal, you know, be like, oh, because then if we correct this, we might prevent complications. Thank you. That's a good
So is it like
question.
worse if they have like a couple like more seizures in the time like you're trying to fix whatever is wrong? Like is like just a couple seizures gonna like affect them more negatively? I don't know, like how like one or two seizures, if they have like long-term effects or not.
I think it depends. I think it depends on what else is going on with the
Yeah.
patient. If they have a lot of like risk factors, like if they had a, you know, hypoxia, ischemia, if they have an infection, like say if you're treating them for meningitis and they're having seizures, you're probably gonna wanna get those seizures under control.
Yeah.
If they're relatively stable and they have like significant obvious electrolyte imbalances, it's probably prudent to treat and correct those, and then move on to medicine if you need it. Yeah, yeah. Another good question. Thank you.
So is there like one risk factor that puts them more at risk for having like epilepsy later? Like I feel like if it's a fluid and electrolyte imbalance and you fix that, is it just because they've had seizures in the past that their threshold is lower, or would it be more like the genetic stuff in addition to having seizures as a neonate?
Yeah, that's a good question. Not necessarily the genetic stuff, but I think the critical, like what they went through in the NICU, you know, if they were hypoxic, again, if they required, you know, a long-term stay, if they were on a ventilator, they had a lot of complications. I think that, because sometimes you can have brain damage, you can have small strokes, little like episodes of this or that could contribute. I think if it's a correctable cause, something that's caught right away, and the baby has more of an uneventful course, it's less likely. But it's kind of one of those things I kept coming across it in the literature, that if they do have seizures in infancy, it does lower the seizure threshold for the lifespan, so you like need to be aware. It's similar to like if someone has a stroke once, they're at risk to have another stroke because they've had the event. So kind of similar, it's just something to be aware of, you know, like parents need to report that, you know, stuff like that. It should be in the medical record, yeah. It's also really important, you know, for you as the nurse to document like what happened. Like, just a quick note, don't have to go into gross detail, but you don't want to just say, you know, 3 a.m., patient appeared to have a seizure, contacted the nurse practitioner on call, came to see the patient. It's better if you kind of add the patient had some left eye deviation and apnea, you know, to just give like some detail so the rest of the team kind of knows exactly what happened and take it from there. Any other questions? So we're gonna, is that okay?
Yeah.
All right.
Great.
So we're gonna move on to meningitis. Alright, it still works, it's just giving this things on the spot on the side.
It won't let you hit the public again.
No, it's like not. Okay, perfect for it. Thanks. Alright, so meningitis in the NICU. Have any of you seen meningitis, bacterial meningitis? Yeah, you've seen it? Okay, yeah. So, oh gosh. So, meningitis in the NICU.
Okay.
Okay. So we have some objectives here. Identify the major organisms that cause neonatal meningitis. We're gonna determine early and late signs of it. We're gonna discuss the diagnosis and treatment of bacterial meningitis, and we're gonna understand the prognosis and outcomes for babies with specifically bacterial meningitis. The definition is infection or inflammation of cerebral spinal fluid, the meninges, or brain tissue. The occurrence is about 5 to 7 per 100,000 infants. So it's rare, but it does occur, and these babies get very, very sick. So it's important to be able to promptly identify it, diagnose it, and treat it. So presentation, the time of presentation, that's gonna help guide to the probable cause. If the symptoms start within the first week of life, that's gonna suggest vertical transmission from the mother, likely group B strep. You might also see E. coli infection with that in the first week of life. And then if it has a later presentation after a week, we're gonna be looking at hospital acquired or community acquired. And you're gonna see different organisms. You're gonna see gram-negative organisms and other staph-type infections with that. So risk factors, the big one is the maternal infection. So group B strep is number one. We can also have HSV, herpes simplex virus, that can cause HSV encephalitis. So that would be a type of viral meningitis. And then what medicine do we use to treat HSV herpes? Excuse me? Valtrex. Is that the same as the cyclovir?
Yeah.
Yeah, perfect, good job.
We treat Valtrex for the parent mom. Baby gets a cyclovir.
Oh.
So yeah, cyclovir is the big one, any type of viral meningitis, a cyclovir. Also prolonged ruptured membranes greater than 18 hours, that can be a risk factor, as well as prematurity. So signs and symptoms, these will be early signs, any symptoms of shock within the first 24 hours. These babies are gonna quickly decompensate, they'll have vital sign changes, respiratory distress, low blood pressure, episodes of apnea, bradycardia, they might develop jaundice, hepatomegaly. You might also see temperature instability and seizures as early signs of meningitis. Later signs are going to be less specific, maybe high-pitched cry or irritability. You might see drowsiness, the baby's more sleepy, also bulging fontanelles. There might also be a rash. It's described sometimes as like a blueberry muffin type rash. That's going to be more associated with a later sign. So how is it diagnosed? Lumbar puncture is the gold standard for diagnosis. Ideally, the lumbar puncture would be completed before any antibiotics or antivirals are started, so they can look at the CSF and find out exactly what's going on. If you start antibiotics prior to lumbar puncture, they're gonna already have had some treatment, so the CSF is not gonna be as clear a picture. So they analyze the cerebral spinal fluid, a gram stain. Typically you'll see a low glucose level with meningitis and elevated protein in white blood cells. So have any of you participated in a lumbar puncture? Yeah?
Yeah, I did.
Yeah, okay. So I've done them lots in adults. I can't even imagine with the little one. Kathleen showed me that this video, which I'm gonna play. It's about 5 minutes long. And then we're gonna have a little discussion about it when it's finished. I also, Kathleen told me that the hardest thing with the lumbar puncture is, especially if it's a bigger baby, a term baby, is holding them in position, because you'd be very surprised how strong they are. So I found these, which I'll just pass around. It shows the two positions, the side lying position, and then there's also a seated position. So it shows the landmarks and the holding. So I thought that was just a good thing. So I'll pass that around. On the video, please. Sure.
This young fellow is a newborn. Unfortunately, he's got a temp. And because he has a temp, we're going to do a septic workup on him. Mom's agreed to let us use him as part of our video demonstration. So the septic workup for anybody this age consists of three things. We need to get an IV access, blood cultures, urine for culture and urine analysis, and a spinal tap on him. So we're going to start with the spinal tap first. What Rachel's going to do is give him a little bit of tooth sweet. And what this is a 25% sucrose solution. It's basically within a couple minutes will make him a little bit sleepy. Now it doesn't make him completely sleepy, but it slows him down a little bit, make it a little bit easier for him to tolerate the procedures that we're going to do on him. If the baby's a little bit older and we're doing the septic work on them, then what we generally tend to do is give them some type of a sedative, either ketamine or something along those lines. Now, first thing we're going to do is just kind of take a look back at him and see if we can figure out where we're going to go. Here's his iliac crest. We're going to drop straight down from the iliac crest. Now, the most important thing, though, is for the holder to be able to position him in a number of different ways. And when you're holding the baby, there's a couple of things you have to worry about. There's this plane, and this plane. And what you'll see is when Rachel and Nicole hold him, they're going to kind of flex him this way. And the most important plane is this plane, because if you roll him over this way, when you put the needle in, you're going to miss where you're going to go. Okay? So I'm just going to take a feel right now. And here's his iliac crest, right about here. And right off of that, right down around here is the spinous inner space that we're going to go in between. He's already not too happy with me. I tend to mark the area with a little bit of a push with my fingernail there, and you can see. And then what we're going to do is numb them up, or clear them off here. And the most important thing in this respect is to get him some anesthesia. So the last thing you want to do is stick a needle in this poor guy without numbing him up. Now, when we're ready to go, we're going to bring Grandma over here, and she can talk to him while we're doing the procedure, because he certainly knows her voice a whole lot better than mine. All right, buddy. We're just going to put a little bit of numbing medicine right over here. And you can see it raises the wheel, but then we'll just take a little bit of pressure. That'll squash that wheel down and spread the lidocaine out. That'll make it much more comfortable for this poor guy. There we go. Okay. Yeah. Grandma's right there. And we do leave Mom and Grandma in the room. It's kind of the best thing for the baby.
Everything? What do you want?
Okay. That one. All right. Wish I got Tom over here, I can hand the tubes to. And, okay, ready, Rachel? Okay, so Rachel's gonna get a bit of a pretzel there. I'm just gonna hold that way a little bit.
It's okay. Grandma's here.
All right.
Okay, puppy.
He's doing very good. He's happy. I think he's mad because he can't get the grant. Now you can see he's a little on the slight side, so we didn't have to go in quite so far. Now the success of the procedure is 100% dependent upon the holder. It's got nothing to do, it's got nothing to do with the person with the needle. Everything else is all they do is just go straight. It's your ability to hold them still. And then you always put the stylet back in before you remove it. Take that out. Oh, you did great. That's what looks nice and clear. Just give you that in the straight and narrow a bit. Thank you, Rachel. I'm gonna pass these off. Nicole, I'll give them up to you. What we're gonna do.
You have little puppy.
Nice and clear, guys. It's good. Yeah, that's good for him.
Okay, so that video, there's a lot of good things about that video, but there's also some things that stick out as maybe not best practice. Did anyone see anything? Yeah. He didn't have gloves on for the initial part, up to cleaning the baby and even administering the local anesthetic. So that's not good. And then he did initiate the sterile field. His sterile technique was a little not great. Did anyone see anything else? I just noticed that the syringe he used to inject, he recapped it when it had a safety on it. So, but it's a good video. It shows, the process, and like he says, the most important part is really dependent on the holding. So that's going to be our role in that procedure as nurses. And then with the CSF collection, we can never tube CSF. It needs to always be hand delivered to the lab. So that's something that after the LP is done, we'll make sure the specimens are labeled properly and that somebody hand delivers them to the lab. So other workup, we're going to do a septic workup. So that will be blood cultures, urine culture, probably do urine specific gravity, CBC with diff, probably ABGs, BMPs. They might do coagulation studies, especially if there is any petechiae, abnormal bleeding. I would think they probably do coagulation studies before doing an LP, just to make sure there weren't abnormalities there. And then so the treatment, early initiation of antibiotics is essential. We don't wait until culture results or LP results are back. They'll start broad spectrum antibiotics as soon as possible. Antibiotic therapy is dependent on the recovered pathogen and the clinical response. So depending on what the blood cultures and the LP show, that's going to guide which antibiotics are used. So typically they'll start with empiric broad spectrum antibiotics, and then as the results come in, they'll make it more personalized. They'll match the bug to the drug to give the correct antibiotic therapy. Definitely collaborative. They'll consult with infectious disease specialists and with pharmacy to make sure it's the right drug and the right dose. We also have to watch, if it affects the kidneys, how well the kidneys are clearing the drug, and also watch for the development of any reactions to the antibiotic, secondary reactions like developing thrush or any signs of that. So it's a longer course of treatment, 14 to 21 days is common. Sometimes they'll do serial cultures, blood cultures, lumbar punctures until they start getting samples that are free of infectious organisms. So as the nurse, our goals are to provide supportive care. These babies can become very, very sick. So we're gonna monitor for seizures, they might need anti-epileptics. We're gonna manage their ventilation status, make sure they're protecting their airway, do they need oxygen, do they need BiPAP? Fluid balance, they might need inotropic drugs, and we're gonna provide a lot of support and education to the families. Imaging, they might need a head ultrasound. That would be to look at ventricular size, determine if there's an interventricular hemorrhage. They might do an MRI to look for areas of infarct and cerebral edema, so you can see swelling on the brain with an MRI. And outcomes are largely dependent on how quickly the meningitis was detected and treated. It occurs, like I said earlier, it's a rare occurrence, but it's very closely associated with mortality. One of the articles I read, it said it was about 10% of infants with bacterial meningitis die. And then up to 50% will have significant neurological issues, including they might develop hydrocephalus, seizures, they might have hearing and visual loss, or cognitive delays, mental and motor delays. So this is my reference list, and that's it for meningitis. Does anyone have questions? No. Thank you so much. Appreciate it.
Thank you. Did you like the video?
Oh.
He's